but to talk to you today about the academic Viva. So I've got a 20 to 30 minute presentation. I've tried not to make it too dry, although it is naturally a dry subject, and I thought we'd have questions and discussion at the end for those people who are coming up to the Viva who perhaps want to ask more questions. So as a kind of recap, what's required for the academic Viva? Well, you need to be able to appraise a paper essentially in 30 minutes and then present your findings to 2 examiners over the course of 15 minutes. You will be taken into a quiet room with other candidates, given a desk and a load of highlighters, and allowed to read the paper for 30 minutes. And at which point you can write down your thoughts. You're then allowed to take those notes in with you. And the paper can be quite old. I think mine was 20 years old and was a registry-based study. So they're not all RCTs. It's not rocket science. I think that's the most important thing to say here. And I think if you have a relatively structured way of looking at the paper, and presenting your thoughts on it, actually you'll be able to achieve 6s and 7s relatively easily. They're looking really to see that you can read the article in that period of time and articulate the findings to them, and it should be a discussion. So ideally they'll ask you to start with what you think of the paper, and you can then lead the discussion yourself by how you present the findings. Don't do what I did, forget to mention the abstract, because there are points associated with these different things. And whilst I can't share, I didn't think I was allowed to share with you the documentation that they send you just prior to the exam. You will get given a document about the academic Viva when you've registered and when you're coming up to the exam a few weeks before. And essentially the things in that document are the things that you want to tick off as you go through. So what is critical appraisal? Well, it's the systematic evaluation of research papers from a variety of different sort of areas, and you want to be able to really kind of ask these questions of the paper as you go through and do it. So does the study address a clearly focused question? What are the methods that the authors have used to address this question? And then looking at the validity of the study results is important, and we'll come on in a bit to look at that. And how can you apply these results to your patient population? So number 3 and number 4 are really talking about internal validity and external validity. And again, I'll cover that in a bit more detail as we go through. This is not meant to be a kind of be all and end all to critical appraisal, but just kind of a useful starting point maybe. And I think, yes.
Just stop you there very quickly. Your slides aren't moving through. I wondered if
you helpful.
Yeah, I don't know if you were moving through them.
Yeah, I was. It's that thing with Teams where when you go to slideshow, it doesn't share them. Do you just want me to show the slides like this and then?
That's fine. Whatever works for you, as long as they're kind of keeping up with.
Were you just stuck on that one?
No, the very first one.
Okay,
yeah,
right. So right, that's what is required. Yada yada yada. Critical appraisal. So I've just been covering those points. So as I was saying, can you see that now?
Yeah. That's great.
Okay. So point 3, internal validity. Point 4, external validity. So and we'll cover that in a bit more detail. As I say, there are lots of ways to do this. This guide is by no means the dogma, and I think you have to kind of slightly pick your own way through it and get into a bit of a patter yourself about how to present the findings. So I think they sometimes ask you about this. So I thought I'd give you this to start with, because when you first present the paper to them, you want to have an idea about what type of study it is that you're going to be talking about. And this is a slightly old-fashioned now look at the kind of levels of evidence, starting with systematic reviews, and as everybody knows, working your way down to ideas and opinions. I think the fact is now that large cohort studies or case-controlled studies, if performed in a way that minimizes bias, can actually give really valuable information and are a way of looking at rare disease outcomes and rare diseases that it's really quite challenging to look at in RCTs. So there's a kind of horses for courses type picture here. So you want to make sure that the way that the study addresses a particular research problem or a particular clinical question is the right way to do it, if you see what I mean. This website here, the Oxford Centre for Evidence-Based Medicine and the Levels Working Group, is an invaluable resource in terms of critical appraisal, and is essentially my go-to resource when I come to appraising papers, particularly when I was kind of first starting out in terms of this. I think a really good way to present your findings is using the PICO method. It's also a really good way to think about setting up a systematic review or how you're going to address a clinical research question, and it allows you to be very systematic in terms of how you present your data, how you present your appraisal and the initial part of your appraisal to your examiners. PICO, as you can see, stands for patients, intervention, what are the control measures, although that can be slightly difficult to pick apart sometimes if you have a non-randomized study, but if you can pull apart what they're trying to do with the paper, then you can put those into intervention and control, and the outcome measures used. And actually the outcome measures are often some of the most important bits to critically appraise, because that's where the real nitty-gritty of what they've done with the research and how it applies to your patient population and the internal validity of what they've done really applies. So what's internal validity? Well, internal validity is the extent at which the observed results really represent kind of the actual thing or phenomenon that's happening in the population that you're studying. And as a result of a change that you've made, such as in an RCT or a drug trial or whatever, and not due to systematic methodological errors or measurement errors through completing the research. And really this comes down to then measuring bias and how we assess bias in studies. And there's lots and lots of different causes of bias or sources of bias that you can pick apart. And commonly, these are the kind of main ones, although there are lots of others. And it's worth, I think, recognizing the main types of bias, so that when you can assess a paper, you can start to pick out the different types of bias, and you can add those into your discussion around the paper, particularly in the kind of critical appraisal bit once you've presented the main findings. And these are the kind of four main ones that I tend to look at. So selection bias. So are there differences in the groups that are being studied? And this often comes down to poor quality randomization, or which can be things like block randomization that's done badly, so that the people who are randomizing know which group the patient is going to go into, or so they'll have a block, say, of 5 or 10 patients, and they'll know that there's going to be 5 in each group, and so by the time they come to 8 and 9, because they've randomized the previous few patients into the study, they'll know that those patients are going to be in a particular group. And if they don't have equipoise, then the people carrying out the study will want to put the patient into a particular group or not randomize them into the study, so they can choose to affect the results that way. Performance bias is important. So are there differences in how treatment or care is being delivered to the patient? And that can be quite difficult to pick apart. exclusion bias is a really important thing to look at, and lots of trials don't really present how the patients have withdrawn from the trials and what the reason for withdrawal was, and that then comes down to kind of intention to treat analysis and that type of thing, and detection bias. So this is how you're measuring your outcome assessment and whether or not you're measuring a true effect. Which leads nicely onto outcome measures. So the whole point about outcome measures is you want them to be able to say that from the measure that you're using, particularly if it's a surrogate endpoint, and I'll come on to a surrogate endpoint in just a second, that the test that you're using measures what you want it to measure. You need to make sure that, for example, if you're, say, following hernia recurrence, that you've got a long enough length of follow-up so that you're picking up all hernias. It's no point in having a 2 or 3 month follow-up for incisional hernia formation because they happen later. So you have to make sure that the length of time that you're looking at an outcome is long enough to pick out the outcome of interest. And there are these kind of fancy terms for the different types of validity, but they're essentially are what you're measuring truthful to what you wanted to measure. People are welcome to ask questions as we go through. And that surrogate endpoint because it's easier to measure and it's possible to measure that in a more reasonable time frame. So biomarkers, I suppose, come into the category of perhaps a surrogate endpoint, and the validity of that surrogate endpoint has to be kind of predetermined before it's then used as that surrogate endpoint. So in rectal cancer, you might say that tumor regression grade, pathological tumor regression grade after rectal cancer surgery could be a surrogate endpoint for overall or disease-free survival in the long run. And there's some studies that say that it is a good endpoint, and there's some studies say, well, TRG is not a good endpoint. But there's huge numbers of these surrogate endpoints in surgery, and you have to get really careful. You have to be really good at looking for them so that you're careful not to mistake a surrogate endpoint for a true endpoint. Fine. So then you have to look at a bit of the stats. And as much as everybody loves stats, we'll go into a bit now. So the power calculation is important, and you want to, particularly in randomized trials, make sure that they've done one and that they've stipulated what the different things are in the power calculation. So it's quite an easy way to not falsify data, but to try and get a result that, or try and do a study knowing that you're not going to achieve a result. The easiest way to fudge power calculation is to say to have a bigger than expected difference between the groups, and that's the most common way, and that leads to type 2 error, which I'll come on to, type 2 statistical error, which I'll come on to in a second. So to do a power calculation, you need to know the difference between the groups, or the expected difference, the power that you're happy with, and most people are 0.8 to 0.9, and the significance of the study, and that's the kind of p-value that you're happy with, and that's the chance of getting a result, and that's 0.0. Most people have 0.05. If you push up the significance value, so 0.01 or 0.001, then you're going to change the number of patients needed, because you're going to have more patients to show that difference, which is a more stringent difference. And as I say, if you want to see a higher significance, then you're going to need to either increase the size of your groups, or some people, and this is the bad way to do it, will say, well, instead of only expecting a 5 or 6% difference between groups. We actually expect a 20% difference between groups, and that therefore means that they don't have to randomize as many patients into their study. But that means that they'll miss a significant difference if there is, say, a 6 or 7% difference between groups at the end of the study, for whatever your outcome measure is. Then that won't be statistically significant, and therefore you'll get a type 2 error. So you'll accept the null hypothesis when that's actually false. So this is really important. You need to look at the numbers accepted in the study, and you need to look at what the expected difference is that they've said between the groups. Because you need to make sure that you have a clinically relevant difference, but not one that's so big that it's ridiculous and that reduces down the sample size. And as I say, the reason for looking at all of this is to think about statistical error. And by far and way the biggest type of statistical error is type 2 error. So you're telling the patient that they don't have a disease or they don't have something. You've accepted the null hypothesis, but actually that's incorrect. They are actually pregnant in this case. And the converse is type 1 error, so a false positive, where you're saying to someone, well, actually, yeah, we think there is a difference here, that you do have something, but actually that's incorrect. And this sometimes is a problem in massive studies where you have huge numbers of data, and so the ability to derive a statistical difference is much more likely. The other way that this occurs is through multiple hypothesis testing, and I'll come on to that shortly. I think it's really important that you guys are able to recognize different types of data distribution, because they're obviously going to be in there. In the paper that I was given in my exam, there was some really complex statistics that I didn't know what they were talking about. So I just said that. I haven't come across the statistical methods that they've used, particularly in the first couple of figures, there were routine statistical methods. And in the second couple of figures, there was some complex kind of modeling stats. And I think it's reasonable to say I haven't come across that type of statistical method, rather than trying to bullshit your way through, because they'll just recognize it. So it's important to think about how data are distributed. Parametric versus non-parametric is the kind of classical way of looking, and the normal distribution here on the left is an example of a parametric distribution. It's important to remember that the normal distribution is plus or minus infinity, and it's also either side of 0. Actually, the vast majority of medical data is not normally distributed, but approximates to a normal distribution. And actually, lots of medical data is in the log normal distribution. And this distribution is a positive distribution, so it's only greater than 0. As the distribution becomes less right skewed, so this is right skewed, where the mean is to the right of the median, as the data becomes less skewed, it starts to approximate a normal distribution. However, there are differences still in the mean and the median at that point, even though they start to get close. And so actually the majority of medical data should be considered as non-parametric, unless you log transform the data, and then you can start to perform parametric statistics on it. But that starts to get quite complex, and you might just want to use non-parametric statistical tests. It's important to know a few of those, and I'll give you some examples in a second. Fine. So those are different types of distribution. There are large numbers of data distributions. And one other one that's important to recognize is what rate data is distributed as. Often in medicine we'll have an event rate, and i.e. number of cases per unit of time. And this data is not normally distributed, despite it being the summary measure being the mean. And so you have to use non-parametric statistics to analyze Poisson distribution. This is again a really common data set, and as you can see with the Poisson distribution, the shape of it starts to look like a normal distribution as you move to the right hand side of the graph, but it's not normally distributed. So I think just do some and use that reading to work out what your statistical tests are that you might want to use. So that when you come to present your data, you can recognize some of the kind of entry-level statistical tests that have been used and present those to your examiners. So more stats, you'll all be happy about that. So what type of measurements has been used is another critical question, so that you can work out you can then work out what statistical test to use, because you need to know what type of measurement that has been used, i.e. is it a continuous measure, is it a categorical measure? So going back to the TRG point, TRG would be a categorical measure because you have TRG 0, 1, 2 and 3, whereas a continuous measure would be something like height or weight, and you can then use the correct statistical test for your type of measurement. I think it's important to recognize that categorical data can't be you can't really summarize categorical data into means. So when you start to see that, you've got to start to wonder, did they have any statistical support within the study? So again, using TRG, if you have a mean TRG of 2.3 is utterly meaningless, because a patient is either TRG2 or TRG3. Nobody is a TRG 2.3. So the median would be the correct summary measure to use at that point. So again, do a bit of reading. There's loads of resources online about this, and you don't need to have high-level statistical knowledge. You just need to understand basic tests and have a basic understanding about different types of data distribution and what measurements. So I think the final bit to say on statistics is regarding multiple hypothesis testing, and again, this is really common in medical papers, and it's important to recognise it. It's otherwise known as the multiple comparisons problem. And the issue is that if you perform 20 single hypothesis tests on 20 bits of data, all with a significance level of 0.05, the probability of observing just one significant result that is due to chance is 64%. So the more in a paper that you just run through doing single outcome measures tested with individual tests, and they can be any of these individual tests, it doesn't matter, it doesn't have to be somebody just doing a t-test repeatedly, then you're likely to get a significant result. And it might be that actually the outcome variable of the surrogate endpoint that they've tested is the one that is the significant result that was due to chance, but you won't know. And essentially it means that the statistical analysis that paper has performed is relatively meaningless. So what's the answer? The answer is to do ANOVA for parametric data, or Kruskal-Wallis for non-parametric data, and these correct for some of the issues that you have with multiple hypothesis testing. There are post-hoc tests, and there are a huge number of post-hoc tests available that look at different types of data, and choosing the right post-hoc test is important. I think in the study, in the study that you're given in the exam, if they start to use post hoc tests, then and you haven't recognised what the test is, then it's reasonable to say they've used a post hoc test. They're probably wanting to control for multiple hypothesis testing, and I would need to look up what that hypothesis test is, because I don't recognise it, but that would be the reason that they're using it. So again, don't try and bullshit your examiners. Just be open and honest with them, and just say, oh, I've not seen this one before. The other answer is, but not in the exam, but when you're performing this type of research, is to get a statistician involved, and you can look for that in the you can look for that in the paper. So if they're starting to use complex statistics or complex power calculations to try and get around a particular clinical problem, then have they used a statistician? You can comment on that in the paper. In the authors section of the paper, and so you should be able to see that. Fine, right, you'll be glad that stats is over. Next thing to say is that the way the paper is presented should adhere to reporting guidelines. Now, reporting guidelines are a relatively recent thing, and so if, like in my exam, you were given an older paper, you have to recognize that perhaps the reporting guidelines weren't around at that point. And reporting guidelines essentially help somebody who's appraising data, as well as a researcher, look to see whether or not certain things have been added into the paper to help with readability, to help with understanding, and to make sure that that paper is reproducible at the end of the day. And there are a large number of, as I say, reporting guidelines. The Equator Network has a large number on their website. They tend to be designed in consensus, so they're not by any means perfect, but most studies nowadays and most journals will ask author to submit a reporting guideline or reporting checklist when they submit a paper. So it's important to look for that, because it brings that paper up to a certain level, a certain standard. So you might want to have a look at the Equator Network just to get an idea about what is available for different types of study. And then finally, when you're looking at the paper, is the discussion. And in the Viva, the examiners place a fair amount of thought into how they've presented the discussion. I think what you want to see is whether or not the authors are misrepresenting their data, and that can happen. Or whether or not they're saying their finding from their study is the best thing since sliced bread, and actually everybody should be doing it. And actually, when you look into the data, that's not strictly true. You can see whether or not there's any novel observations within the study. And you can start to apply what they've used and to existing guidelines or other published papers. And that's where you start to get some of the higher marks in the Viva, is where you can start to do that. And you can also start to apply it to your knowledge of healthcare in general. So my paper was on vascular surgery in AAA database, and we moved, and centralization of AAA care, and we moved on to talking about, because there were two colorectal surgeons, centralization of rectal cancer. And how the paper that I'd been asked to appraise related to the argument about centralization of other services, and not just what was being examined in the paper. So be ready to answer some of those questions, and actually, if you're starting to talk about that type of stuff, you will hopefully be getting the 7s and even 8s, and you can be recouping marks that you might have lost elsewhere within the exam. And I think then finally, then this all leads on to this whole concept of external validity. And I know Rosie's recording this session, but the slides can be sent around, so these are slightly there, so that if you want to look through the slides at a later date, you can. So external validity is all about how you can generalize the findings of the study to other situations, and particularly you want to know whether or not the findings from the study represent your population and the application of that data to your clinical cohort. And so these are some of the questions that it suggests that you might want to discuss, and certainly this is kind of higher level. When you get to this point in the exam, if you're able to present some of the external validity, then I think that again is going to be giving you higher marks. so it's all about whether or not the patient group that they've selected is similar to your patients, and lots of that comes down to looking at the demographic tables in the study, because there's no point in trying to apply something that, say, has been done in a group of 40-year-old patients to a group of patients perhaps in their 80s, or something that's been done solely in men to women. So yeah, is the patient group that they've looked at significantly similar to your patient group? Or has it been a very pragmatic study? Is the patient group really really broad, in which case to your very select group of patients that you're thinking about applying it to, will it work in the same way? I think this is a really important question, and again comes down to kind of the expected difference that the study has tried to achieve. So is there a clinically relevant benefit? And that again comes down to this question about have the study designers and the authors said that there's going to be a 30% difference in hernia rate, when actually clinically that you might only ever see a 5 or 10% difference, and they've then looked at a large number of patients and they found a difference in 2% of the population. Sorry, they found a 2% difference in hernia rate, but is that clinically meaningful? So I think having a look at the kind of the differences in the study and whether or not there's a clinically important difference is really important. Another thing is that studies are often performed over a long period of time, and actually perhaps the study was performed when there were no other treatments and a new treatment has come to light, or the study was done and they have the standard of care group is not actually the standard of care. Is another treatment better? So and that's where you have to apply your knowledge of that clinical problem, which will get you those higher marks. And then finally, it's looking about whether or not the treatment is something that could be applied to your group. So this sometimes happens in studies performed in other parts of the world, where the kind of patient values might be slightly different to patient values of your own patient group. And I think it's important to keep this in mind when you're looking at a paper. Is what they've done going to be reasonable to my group of patients? So I think I will leave it there. That's about 25 minutes, and I welcome any questions. I'll stop sharing. Silence. Has everybody gone to sleep?
Thanks so much, Adam, for that. That was a really great talk. Oh, I don't know if my camera's working. Are you able to hear me all right?
Yeah, I can hear well.
I just had one question, and anybody else feel free to either speak up or put something on the chat questions-wise. But I was just wondering what your experiences of journal clubs have been throughout your training. I feel like this side of kind of academic papers hasn't been a huge part of my training, but always keen to learn more about it. And I know there surely is a benefit from journal clubs. Do you feel that they have been very beneficial for you and your knowledge about it?
Yeah, definitely. And I think for the main reason that you're just practicing using these skills. I think if you try and do this every now and again, then I think it can be quite daunting. And I think what you want to do is just get into the habit of just being able to go through a paper and look for these things, and then present your findings in a way that is not flashy, but is just coherent and sensible. And that's what they're looking for in the exam. You're not going to be examined by an academic professor of surgery from Birmingham or London. And I think, and if you are, you're unlucky, and they're not going to be harsh. They're going to want to be nice. They're going to want to have a discussion. So I think if you present your findings in a sensible way, you've looked at the statistics, you've looked at what they've said, you've applied it to your own patient groups, then I think yeah, it's I think that's the way to do it. We tried to run some journal clubs during the first lockdowns, and in the evenings, and initially they were well attended, but then later on I think there wasn't interest. I don't know what the answer is to journal clubs. I think we're doing some at the BRI, but attendance tends to be relatively low, and I think generally people aren't particularly interested. But I think it's a good way just to discuss a paper and think about how research applies to your day-to-day work.
Thank you. I think there's a
Oh yeah, I can see Andre's one.
Yeah.
What is the balance of how critical or not to be when presenting? Yeah, Andre, I think you're right. It is very easy to find flaws in papers. I think what you have to do is present those flaws in a very structured way, and I think I don't think you need to think about a shit sandwich, but I think if there are failings in the paper, just present them as that, and just be honest about them, because there's no point in glossing over something that is a major flaw in a paper. So for example, if you can see that, so I keep on going back to this thing about people picking too big a difference between study groups. So if you can see that or for example, if they've not had a long enough follow-up, if that is a major flaw in the paper, then I think you have to bring these things up. I always present the critical appraisal at the end. So I always say the limitations of this study are, and maybe give 2 or 3 points, and then say, as a result, it might be hard to implement this research to my patients because they don't fit in, the demographic picture is different, whatever. But I think as long as you're not saying the study's crap and I would never do it, I can't believe the authors have done this work, then if you're professional about how you present those, then I think it's fine.
Brilliant. Lovely. Adam, thank you very much for that. You kindly said that you would share the slides, so I can always email them out via the kind of main mailing list if you're happy with that.
Yeah, I'll send them over to you. And I think so I have been over the past couple of years doing FRCS Viva practice just with people coming up to it, and I think Chrissy is arranging some for the new year with the group that's doing it in Feb. So yeah, if the group gets too big, it might be that we need to split it into smaller groups, but I'm always happy to do this, and ideally with a beer and pizza, and just make it a bit more relaxed rather than aggressive academic vivering.
Great. Lovely. Well, thank you so
Good.
much for joining us today.
No, thanks.
Brilliant. All right. So our